I know. Can't.
Something on it? Would you be able to like record it, all that stuff on it?
Okay. Mm-hmm. They can see you. Okay.
You can take the mask off.
Okay. 2 minutes. Okay. Thank you.
Do you want to have it off of the screen until you start?
I don't want to touch it.
But you can skip this one.
Sorry. Do you want to like say a quick welcome so we can just. Including us. Do you want to say welcome?
All right. Well, welcome everyone for joining us this afternoon for this talk. And we might wait just a couple more minutes to see if more people sign on. But want to thank everybody who is currently signed on for taking time out of your busy schedules to listen to this presentation. And hopefully it is helpful for you. And most importantly, hopefully can help you with your current urinary symptoms if you're struggling with that now. All right, we'll get started. So again, like I was saying earlier, thank you for joining us this afternoon for this presentation. I hope that you find that it's helpful and informative. So my name is Dr. Michael Cady. I'm an OB/GYN at in Crosby here at the Cuyuna Regional Medical Center. So we have been practicing in Crosby for the last 16 years. We started in 2004. And yeah, it's a privilege to be able to talk to you all this afternoon. As OB/GYNs, we commonly see women with urinary symptoms. And so we realize that it's a common problem and that it greatly impacts your quality of life. So we always feel grateful and humbled to have patients trust us with our care for them and to be able to help them with their urinary symptoms. So one of the things that I always like to try to do is encourage other care providers to ask patients about urinary symptoms. And the reason is that, you know, patients, given the nature of the problem, are often embarrassed to bring up the problem. So if we don't ask as care providers, patients will oftentimes not bring it up themselves. So this quote here is something we commonly hear from patients. This patient said, "I was so tired of rearranging my schedule around the bathroom. It was always on my mind, but I was just too embarrassed to talk to my doctor." And this survey actually showed that 44% of people say that they're embarrassed to talk about their bladder control problems. And so it's time for us as care providers to change that and to make sure that we're asking patients so that we can address these problems that they're having. So the good news, well, the bad news is that this is a common problem, but the good news is that there are many effective treatment options. And so today in this talk, I'd just like to start out by briefly reviewing bladder control, kind of the physiology behind bladder continence and incontinence, and then go through care pathway, different treatment options, and then specifically talk about Medtronic's bladder control therapies. Also, I'd like to mention at the end of this talk, we'll have an opportunity to do questions and answers. And I just wanted to remind everyone that all questions that are submitted are anonymous, so you don't have to worry about that. So when we talk about OAB, which stands for overactive bladder, it's important to realize how common it really is. In fact, 1 in 6 adults struggle with overactive bladder. And overactive bladder affects women and men of all ages. And ignoring overactive bladder symptoms can result in loss of sleep because patients are often getting up at night so frequently to go to the bathroom. Also can lead to loss of confidence, loss of self-esteem, and poor feelings of general health. So approximately 37 million adults in the United States struggle with overactive bladder. And that's compared to 12 million adults in the United States with vision problems, or 30 million adults in the United States with diabetes. So you can really see what a big problem this is. And I think that oftentimes patients believe that it's not nearly this common. And part of that reason is, I think, given the nature of the problem, they're afraid to talk about it, not only with their care providers, but also with family and friends. So because they're not talking about it, they feel somewhat isolated and feel as though they're the only ones that are struggling with this problem. But it is really very common. And the good news is, in the vast majority of cases, it's very treatable. So what is normal and what isn't? And this is an important question because I think what oftentimes happens is as patients slowly deal with their bladder symptoms over their lifetime, they almost forget what normal used to be like. And then what is abnormal becomes, in a sense, normal for them. But if you are saying to yourself that you're going to the bathroom more than 8 times a day, that would be considered abnormal. Also, other abnormal symptoms would include a sudden urge to go to the bathroom. And sometimes that urge is so strong that you can't suppress it, and it results in urinary incontinence. Patients will oftentimes describe planning activities around the bathroom. We call that bathroom mapping. And so commonly they'll know where all the bathrooms are in the areas that they tend to frequent. Patients also will monitor how much they drink, and sometimes this will lead to dehydration because patients will either consciously or unconsciously fluid restrict in order to minimize their urinary symptoms. And then unfortunately, this can lead to other problems such as dehydration and constipation. And then of course, patients will use pads to control urinary incontinence. So the bladder, as all of you know, is an organ to store urine and then periodically empty the urine throughout the day. So the bladder is actually a type of muscle called made up of a type of muscle called smooth muscle. So we have muscles, of course, all throughout the body, and many of our muscles contract on and off all day long. The bladder muscle is actually a quiescent muscle, meaning that it really shouldn't contract very much throughout the day. It should just passively fill. And then when the bladder is about half full, it begins to send signals to our brain telling it that when appropriate, go to the bathroom. And then once in the bathroom, nerve signals are sent back down to the bladder, telling the bladder to contract and empty. And then that process starts all over again. What happens in women who are struggling with overactive bladder is that communication pathway, for reasons we still don't completely understand, becomes dysfunctional. And so the bladder, in a sense, takes on a life of its own and contracts, even when the brain doesn't want it to. When the bladder contracts, that creates a strong urge that's sometimes so strong that you can't suppress it. And that can oftentimes lead to bladder urgency, bladder urinary frequency, and also urinary incontinence. So what causes bladder control problems? It's important when we see patients that we ask about, dietary habits, their daily habits, including what they eat and drink. And this can play a very important role in their bladder symptoms. For example, caffeine and alcohol are what we call diuretics. So that means that those chemicals cause your bladder your body to create more urine, which causes your bladder to fill up more quickly. So if patients are drinking a lot of coffee, tea, or other caffeinated beverages throughout the day, that can lead to a lot of overactive bladder symptoms. Also, if patients are drinking a lot of alcohol, that can also worsen their overactive bladder symptoms because it causes their bladder to fill up more quickly. And the more distended that your bladder is, the more potential there is to experience overactive bladder symptoms. Also, certain medications can cause worsening of bladder symptoms. Commonly, patients will be on medications called diuretics. So just like caffeine and alcohol are diuretics, certain medications are also diuretics, meaning that they make you urinate more frequently. So a common medication would be Lasix. This medication is prescribed sometimes for patients who have congestive heart failure or swelling in the lower extremities, and also sometimes prescribed to control high blood pressure. So it does a good job at controlling those things, but the downside is it can worsen urinary symptoms. There's also some medications that can make it harder for you to empty your bladder as well. So when we see our patients, it's important for us to do a good review of medications in order to make sure that if we can change medications when appropriate, we can do that in hopes of helping with urinary symptoms. Pregnancy, of course, can cause changes in bladder symptoms, childbirth also, because of the obstetrical trauma during vaginal deliveries, and then pelvic floor injury, which most oftentimes occurs during delivery from obstetrical trauma, but also can happen at other times, such as motor vehicle accidents, and that can play a role in incontinence as well. So when we see our patients, it's important for us to establish or determine what type of incontinence they're struggling with, because not all urinary incontinence is the same. So I'd like to just spend a little bit of time now talking about the different types of urinary incontinence that we'll see as care providers. So the first type of incontinence that we will talk about is called stress urinary incontinence. And then we'll talk about overflow incontinence or urinary retention. And then lastly, overactive bladder, which we've been talking about already a little bit. Okay, so what is stress incontinence? Stress incontinence is leaking during certain activities of stress, such as laughing, coughing, sneezing, and then also other activities like exercise, running, jumping, lifting. And interestingly, stress incontinence is not so much a problem with the bladder as it is a problem with the support underneath the urethra. And the urethra is the tube from the bladder to the outside of the vagina, which runs along the top part of the vagina. The support underneath the urethra is important because it stabilizes the urethra during times of activity and stress. If that tissue is weakened, then the urethra becomes hypermobile, meaning that it moves excessively and can cause spurts of urine throughout the daytime. So things that can cause weakening of this tissue can include obstetrical trauma at the time of vaginal deliveries. Also, as we age, our tissue gets weaker, so that support becomes more attenuated and weakened. And then lastly, some of us are just inherit weaker tissue, so genetics plays a role into stress incontinence as well. This is a very common problem in the United States. And the good news is it's very treatable. We see a lot of women who struggle with this, and we have good treatment options. There's two main treatment options to help women who are struggling with stress urinary incontinence. The first is to recommend physical therapy. So oftentimes we'll think of physical therapy in the realm of orthopedics or back pain and sports injuries, and that of course is true, but physical therapists can also help our patients greatly with urinary incontinence. For women who struggle with stress incontinence, physical therapy can be helpful because they can teach patients how to strengthen their pelvic floor muscles, and that can lead to reduced stress incontinence and sometimes elimination of their stress incontinence. These exercises are called Kegel exercises. And so sometimes I'll bring this up to patients and they'll tell me, well, you know what, I've already been doing Kegel exercises on my own and it hasn't helped. In those cases, I still really encourage that they consider seeing a physical therapist, because it is very possible that they're not doing the Kegel exercises correctly. And that's where physical therapy can be of great benefit, because the physical therapist can help them, the patients, isolate the correct pelvic floor muscles in order to strengthen that support to lead to reduced leaking. Now, if patients have either decided that they don't want to do physical therapy, or they have tried physical therapy and it has not been effective for them, then there is a same-day procedure that we do here in Crosby. It's minimally invasive. It takes about 25 to 30 minutes. You go home the same day, and the procedure involves placing a small piece of mesh underneath the urethra to stabilize the urethra. And this procedure has been out since the mid-1990s and has very good safety and efficacy data behind it. About 88 to 90% of women will experience significant improvement in their stress incontinence after this procedure. So those are the two most common treatment options that we'll offer women who are struggling with stress incontinence. Now, urinary retention is also a problem that women can experience. We, of course, don't see men, but men can also struggle with this problem, most commonly from an enlarged prostate, because it causes obstruction and causes poor bladder emptying. But for women, the most common cause of obstruction and urinary retention would be what we call pelvic organ prolapse, where they experience the bulging of the vaginal tissue from a bladder or rectal prolapse, or maybe a uterine prolapse. And what happens then in these circumstances is that the urethra, again, the tube from the bladder to the outside of the vagina, becomes kinked, and it becomes more difficult for them to completely empty their bladder. If this happens over a long period of time, what happens is the bladder becomes chronically full and can lead to essentially nerve damage, which inhibits appropriate contraction of the bladder and doesn't allow them to empty their bladder, sometimes even after we correct that bulge. It can also then, poor bladder emptying can lead to leakage of urine, urgency, frequency, and increased risk of urinary tract infections. And on occasion, patients need to use a catheter in order to completely empty their bladder. There are certain conditions that also put you at risk for developing this, such as uncontrolled diabetes due to nerve damage. And there's also other neurologic conditions that can put patients at risk for developing urinary retention, such as multiple sclerosis. And then lastly, as we talked about before, there's medications that can cause poor bladder emptying. And so it's important for us as care providers to look at the medication list to see if we can make alterations to help them with their symptoms. So the third type of bladder symptom that we commonly see is called OAB. Sometimes we call it detrusor instability, and OAB, like I mentioned before, stands for overactive bladder. Overactive bladder, again, is a problem where there's a communication breakdown between the bladder and our brain. And the bladder, in a sense, takes on a life of its own and contracts, creating a strong urge that sometimes can't be suppressed and results in urinary leakage and also urinary frequency. Nighttime voiding is also a problem. We call that nocturia, and that can lead to poor sleep due to frequent trips to the bathroom at night. So like I'd mentioned before, the bad news is that urinary incontinence and these urinary symptoms is really quite common, but the good news is that there are very successful treatment options for patients. And that's our job as physicians to make sure that we can effectively treat our patients with the appropriate treatment options. So what this slide is showing is, first and foremost, we want to make the correct diagnosis. And that's why it's important that we see our patients for a clinic visit so that we can obtain a detailed history and just basically listen to you and hear, what type of leaking and what kind of symptoms are you having exactly. And then after that, it's important for us to do a focused exam to be able to determine, again, what type of incontinence you may be struggling with. And sometimes it's not one or the other, it's a combination of all of these, and we call that mixed incontinence. So like most things, we always like to try to start conservatively and then move towards more advanced therapies. So as I had talked about before, some of the easiest things are just looking at lifestyle changes. So if you happen to be drinking a lot of coffee, a pot, maybe 2 pots a day, sometimes amazingly patients do drink that much. I always say that's an easy place to start, but loving coffee like I do, I understand that it may not be easy to reduce your coffee intake, but it is important to try to reduce or eliminate the amount of caffeine in your diet, also alcohol as well. Exercise is important, primarily with stress incontinence. Weight loss can really play a role in improving symptoms. So just, diet and exercise is important. So we start with those lifestyle changes. If patients have done that and maybe seen a physical therapist and they're still struggling with their symptoms, then we usually will then move on to medications. There are a number of medications approved by the Food and Drug Administration to help women with their urinary incontinence. And these medications are successful in many cases and safe, and then advanced therapies. And so this slide just kind of shows what I already talked about, looking at lifestyle changes through diet, exercise, bladder retraining, we call that biofeedback, that can be done through physical therapy, and then pelvic floor strengthening exercises. One example of bladder retraining that I didn't talk about before, but with overactive bladder, there tend to be oftentimes frequent triggers that will cause strong urges for women. And common triggers include running water. So if you're in the kitchen washing dishes, or you're starting the shower and you're hearing the water running, or maybe going out and getting into the car or getting out of the car, or coming home and putting your hand on the doorknob. All of those things send signals to your brain saying, okay, this is the time to contract now, and create strong urges to empty your bladder. That's a situation where you can learn how to do bladder retraining or biofeedback through physical therapy. And then we already talked about pelvic floor strengthening exercises, again, called Kegel exercises. Okay, so oral medications, again, there are several that we can choose from. And for many patients, this can ultimately be a great treatment option. With these medications, a lot of times patients will ask, well, can I just take it when I go out in the evening or, as needed? But, really you do have to take them every day. Most of them are just once a day dosing, so it's convenient in that sense. Like all medications, there is potential for side effects. To be honest, the side effects aren't very common, but they definitely can occur. And when they do occur, the most common side effects include dry mouth, constipation, blurry vision, and sometimes some of them can cause an elevation in blood pressure. This survey actually showed that 72% of patients ended up stopping their bladder medication within 6 months, either just because they felt like it wasn't successful for them or they were having bothersome side effects. So lastly, I'd like to talk about what we call advanced therapies. And in a sense, I feel like this is maybe the most important part of the talk. And the reason why I say that is I feel like for many patients, their treatment pathway goes up to the point of medication, but not beyond that point. And what I always like to make sure my patients understand is that if we try medication and medication ultimately does not work, that's not the end of the road. There are other treatment options that we can choose. And unfortunately, I think for many patients, medications are the end of the road for them, that they feel like, well, I tried everything. This was the last thing I could try, and that there are not any more options available. But in fact, there are. And the other options available are very effective treatment options. When I see my patients for urinary symptoms, I always like to have them come back in about a month just to make sure, especially if we're placing them on medication, to see how is it working. Do they feel like it's helping? Are they having any side effects? Because if it's not working or they're not able to tolerate it from a side effect standpoint, we can either try other medications or move towards advanced therapies. So when we say advanced therapies, that's what I'd like to talk about now. There's basically 3 options for patients who have failed conservative management options, meaning working on lifestyle changes, altering diet, trying medication. If all of those things haven't worked, you've maybe seen physical therapy, you're still struggling, there's basically 3. And so the first is the Medtronic bladder control therapy delivered by the neurosystem. And the second is the Medtronic bladder control therapy delivered by the InterStim systems. And then lastly, injected medications into the bladder. And it's important to understand the trade-offs before you decide on a particular treatment option. And that's our job as physicians to explain, the pros and cons of each of these management options. So the first one that I would like to go over is injected medications. So the medication that we inject into the bladder is Botox. And so many patients have heard of Botox before because it's used cosmetically to help with wrinkles, but also for other problems like chronic pain issues and chronic headaches. And so the way that this works is that we can either in the office or sometimes in the operating room with some light sedation, place a small camera inside the bladder. It's called a cystoscope. And then once we place the camera inside the bladder, we're able to use a small needle to inject Botox into the bladder. What the Botox essentially does then is calms the bladder muscle down so it's not so irritable. And this can be a really effective treatment option for many patients. It is safe, but it does have to be repeated for as long as you feel like it's working for you. Typically I would say patients need to have the Botox re-injected into the bladder every 4 to 6 months, probably on average, although, I've had patients go longer than that as well. And the other thing that I always like to make sure patients understand with the Botox is that about 8% of patients will experience urinary retention after the Botox, meaning that They don't completely empty, which might require them to do some intermittent catheterization, meaning that they would have to place a small catheter into the bladder on their own at home, which we can teach them how to do. Some patients are okay with that since they know that that's not something they probably have to do every time that they have to empty their bladder, and it also isn't a very common occurrence. But other patients will say, you know what, if that's even a small possibility, that's not something I'm interested in. And then this study here, as you can see on the slide, showed that 51% of patients stopped Botox injections after 2 treatments. So the next therapy option is something called Medtronic Neurosystem. And this has proven to restore bladder function and improve quality of life. It reduces urgency, frequency, and urinary incontinence, and it provides lasting relief without the side effects of medication and or the need of self-catheterization like Botox can. This patient said, PTNM, which stands for percutaneous tibial nerve modulation, has improved my quality of life. It is such a relief not to have to be worrying about my bladder needs. It's a nice sense of freedom. So the way that this therapy works is, I think one of the things that appeals to patients is it's done in the clinic and it does not require a trip to the operating room. It does not require any sedation. And if you can see the picture on this slide, what it's showing is that when our patients come in and they have decided to receive this treatment, one of our nurses usually places a small needle on the inner lower part of the leg to stimulate a nerve called the tibial nerve. And it seems strange that this would help with bladder symptoms since this nerve is so far away from the bladder, but it actually does connect to nerves that provide sensation and function to the bladder and has been shown in well-done studies to provide good bladder relief for a large number of women. So the way that it works is that in the beginning, patients come in once a week for 30 minutes. So the needle is placed and the needle stimulates the nerve for 30 minutes once a week for 12 weeks. And then we don't make any decisions about the effectiveness of the treatment until after the first 12 weeks or 3 months. If after the 3 months, patients say, you know what, this really has made a big improvement in my urinary symptoms, then what we do is we continue the therapy every month. So patients come in not weekly anymore, but once a month for 30 minutes. And then that's usually therapy that needs to be ongoing because if patients end up stopping, their urinary symptoms will come back. So the advantage of this is it's very safe, it's minimally invasive, it's done in the clinic. Downside, sometimes patients just don't want to make that time commitment, especially in the beginning, since it involves coming in every week. But that can be a good treatment option for patients. So lastly, I'd like to just talk about the Medtronic bladder control therapy called InterStim. So InterStim is an advanced therapy that restores bladder function by gently stimulating the sacral nerves. It's clinically proven to stop or reduce accidents, and it significantly improves quality of life. It's actually been approved by the Food and Drug Administration since 1997, which I think a lot of patients are surprised to hear. And actually, to be honest, a lot of care providers are surprised to hear that as well, which is sad in a way that it's been out for over 20 years and people are still kind of learning about it, especially since it is such a safe treatment option and is really very successful for the majority of patients. Some exciting things with InterStim recently, and I'll go into this in a little bit more detail, but let me just describe a little bit about how the procedure is done. It's a 2-part procedure, meaning that the first part of the procedure, in Crosby here, we usually do the first and second part of the procedure in the operating room with some very light sedation to keep you comfortable. The first procedure takes about 30 to 45 minutes and we have you lay on your tummy and we use a type of x-ray called fluoroscopy to help us identify where we need to place a little small flexible wire to stimulate a nerve in your tailbone area. So we place that wire under fluoroscopic guidance. And then once we've determined that the wire is in a correct position, we secure it or kind of tape it down to the buttock area. And then we send you home, and that wire will communicate wirelessly with like a little iPhone device over the next week or two. So every day then, after you have this first procedure, we call you to see how the therapy is working for you. And if you are experiencing at least a 50% improvement, then we bring you back usually a week later to attach a small battery to the flexible wire. And then the second procedure is shorter than the first. It usually takes about 15 minutes, but we also provide light sedation for that second procedure. So both procedures are minimally invasive and just involve a very small incision, very minimal postoperative pain, and very low risk. So, I always tell my patients that whenever you're considering a surgical procedure, ideally, the ideal procedure is always going to be a procedure that has high potential for success and low potential for risks. And I really think that InterStim fits this very well. It really truly does have low risk for, all of the potential surgical complications that can occur, such as bleeding and infection. Those risks are just very, very low with InterStim, and the success is very high. The exciting changes recently with InterStim, the wire did not used to be MRI safe. So if a patient had InterStim and was experiencing good relief of their urinary symptoms but needed to have an MRI, we in the past would then have to remove their InterStim device, then have the patient get their MRI, and then replace the InterStim after the MRI. So the good news now is that all of the leads, the wires that we're placing for InterStim therapy are MRI safe. So you no longer have to have it removed in order to have an MRI. You can safely have the MRI with the lead wire and battery in place. The other change is that there used to only be one battery option. The battery that we still use and have used in the past is about the size of $50. I would say it's very small and thin. Maybe some of you know somebody who's had a pacemaker, or maybe you have a pacemaker yourself. It's similar to that. It's placed just under the skin. And something I didn't mention earlier is that with InterStim, there's nothing on the outside that you have to deal with. Everything is under the skin, and you have a little kind of iPhone device that helps communicate with your InterStim transcutaneously. But what I was going to mention is that now you have two battery options. One battery is now smaller and rechargeable. So you just have to recharge it for a half hour each week. And that keeps the battery charged, and it lasts longer than the implantable battery. So this slide just shows you how successful InterStim can be. So again, this is great news for patients who have gone through all of the conservative measures and have gotten to the point of, needing to consider advanced therapies. This is a very successful procedure, and 84% of women have satisfaction with InterStim, and it's 3 times greater improvements in quality of life compared to medications. And 76% of people achieve success with InterStim compared to 49% of women with medication. Lastly, I should mention too that InterStim, we've talked about helping women with urinary incontinence, but InterStim is also approved by the Food and Drug Administration for treatment of fecal incontinence. So if you're struggling with not only leakage of urine, but also leakage of stool, or maybe just leakage of stool alone, InterStim could be an excellent option for you as well. So is this therapy right for you? You may be a good candidate for Medtronic bladder control therapy delivered by the InterStim system if, as I mentioned before, you have significant overactive bladder symptoms, or you have non-obstructive urinary retention. That means you're retaining urine, but it's not due to pelvic organ prolapse, it's due to some other condition. And then lastly, if you're having fecal incontinence, InterStim can be a good treatment option for you. Also, if you've tried lifestyle changes or oral medications and you haven't had good results or haven't been able to tolerate medications, and these treatment options haven't given you the relief that you want, those would all be reasons to, consider moving forward with advanced therapy options such as InterStim or the neural in-office system. Kind of lastly, in summary, I'll just say as a physician, this is one of the areas that I would say brings me the most happiness, just because we have such a potential to greatly improve our patients' quality of life. And we see it so commonly where, patients will feel like there's really nothing else that they could do. And then to have them find out that there are other treatment options, and not only are they safe, but they're really successful. And then to see them back after the procedure and see that they've really kind of reclaimed their life, that they can then, sleep through the night, not run to the bathroom all the time. They have less leaking or maybe absent leaking after the procedure. It's really just awesome to see. And it is a blessing that we have therapies like this to offer our patients. So just lastly, I'd like to say that, again, it's always a privilege and humbling to take care of the patients we see. And, if you have listened to this talk and you're thinking, yes, I do want to consider these options because what I've tried so far hasn't worked for me. Of course, we would always be happy to see you in clinic and discuss your urinary symptoms in more detail. My wife, Rachel, is also an OBGYN and sees women for urinary symptoms as well. And she also performs all of the procedures that we talked about, including Botox and offering the neural in-office Medtronic system. And then lastly, the InterStim. The best number to get a hold of us is the 218-545-1049 number. And that way you can just schedule an appointment or leave a message with our nurse too if you have just questions that you would like answered over the phone. So I think now we'll do question and answer. And again, like I said in the beginning, all of the questions are anonymous. So I don't want you to feel like your name's going to pop up on the screen if you ask a specific question. Okay, so the first question, sorry, I'm looking up on the screen here, is if I choose to try InterStim, how long after the test procedure would it be before I could tell it was working for me? Yes, that's a great question. So actually, usually within a day, usually by the next day, patients are able to notice an improvement. And so it's usually pretty immediate. We usually do a 1-week trial because I feel like that's sufficient time for sure to know, is it going to work or is it not? For the majority of patients, it truly does work. And when it does, we move forward with the battery placement. But a lot of times what I'll tell my patients is almost the worst thing that can happen with InterStim is that it just doesn't end up working for you. And the reality is it doesn't work for everyone. It works for the majority of patients, but not for everyone. So if we place the little flexible wire and you don't get the kind of relief that you were hoping for, then we do bring you back the next week to remove the wire. But if it does work for you, like it does in most cases, we bring it back to the operating room and attach the battery to the little flexible lead wire. So.
All right, Dr. Katie, I have another question. I also have occasional bowel leakage. Does this InterStim also help with that?
It does, yep, like I mentioned. So the question was, does it help with fecal incontinence? And it does. It's approved by the Food and Drug Administration to treat fecal incontinence. And it's honestly one of the best treatment options that we have now for fecal incontinence. It's placed the same way. And that it can provide good relief for women who have both urinary and fecal incontinence or fecal incontinence alone. So the next question is, how is overactive bladder different from stress incontinence? So stress incontinence is a problem with support under the urethra. The urethra is hypermobile and that causes spurts of urine. So when we are trying to discuss treatment options for stress incontinence, we want to try to improve the support under the urethra, and that can be done either through strengthening of the pelvic floor muscles through physical therapy, like I was mentioning, or a same-day procedure that we do called a suburethral sling procedure, where we place a little thin piece of mesh underneath your urethra to provide long-lasting support to eliminate or markedly reduce the amount of stress incontinence that you're having. Like I'd mentioned earlier in the talk, the procedure is about 90% successful. Overactive bladder is more a problem with the actual bladder. So it's not a support problem, it's a problem with the bladder, and it's a communication breakdown between the bladder and the brain. So the bladder takes on a life of its own and just decides to contract when the brain doesn't want it to. And that can cause urgency, frequency, nighttime symptoms, and leakage of urine due to urgency.
Dr. Katie, what if I've already tried Botox? Would InterStim work for me?
So yep, the question is Botox. If you've tried it already, can you then do InterStim? And the answer is yes. If you've tried Botox and it hasn't worked, you can do InterStim. You could also do the neuro in-office procedure. The same is true too. If you've tried InterStim and it hasn't worked, you can always try Botox. So once you've tried one, it doesn't mean that you can't try the other treatment options.
Dr. Katie, can you please re-explain the battery life on the new one? Also about the recharging it, and will I be able to charge it myself?
Yeah, so the rechargeable battery is it's very easy. This is something we can kind of go into more detail when you come in, to see us for a consultative visit, but we can actually show you what the battery looks like. It's considerably smaller than the battery that we've traditionally been using. You do charge it on your own, and again, it's a half hour once a week, and the battery life is 15 years, as opposed to the battery that's not rechargeable is about 5 or 6 year lifespan on average.
Dr. Katie, if I want to talk about getting an implant, what are the best next steps?
Yeah, so if, like I said, so the question was, if I'm thinking about, advanced therapies, what's the best next step? And I would say to just come in and see either myself or my wife, Rachel, and we could, listen to the symptoms that you're struggling with and then come up with a plan that would be best for you in terms of treatment.
Will the InterStim cure my condition?
So, yeah, I mean, I guess the question is, will InterStim cure my condition? And I guess the question would be, how do you define cure? I think that in a sense, I would say no, just because if you stopped your InterStim therapy, your condition would come back. But what I would say though, too, is that as long as you have your InterStim therapy in place, and as long as it is working for you, it typically provides just ongoing, long-lasting relief of your urinary symptoms. But if the battery stops working and you require a battery change, for example, then you're going to notice that your symptoms come back. But like I had mentioned before, it's very easy, a very simple procedure to remove the old battery and then replace a new battery. All right.
There's 2 more.
Oh, 2 more. Okay.
What does the stimulation feel like?
Yeah, so the question is, what does the stimulation from the InterStim feel like? So the stimulation from the InterStim, women will commonly feel just kind of a slight tingling sensation in the vaginal area or in the perineum, kind of that area where you'd sit on a bicycle seat. And so it's never uncomfortable. It sometimes is noticeable, but it doesn't have to be noticeable in order for it to provide relief of symptoms. But we do usually turn it up high enough so that we can make sure that that is where you're feeling the stimulation, so that we know that we are stimulating the right nerve in the right location.
Does Medicare pay for any of these treatments?
So the question is, does Medicare pay for these treatments? And the answer is yes.
So a patient's interstim has been broken for quite some time. She's wondering if she gets the new one, the MRI safe, how long approximately will it last before she has to replace it again, or will this one last much longer?
Yeah, so there's two components to the interstim. There's the lead wire and there is the battery. So the battery on average should last for 5 to 6 years. And if you choose the new rechargeable battery, like we had mentioned earlier, that should actually last for 15 years. So the second component, so that's the battery. Then the second component is the lead wire. The lead wire should last a lifetime. Sometimes it doesn't, for reasons sometimes we can't explain, or sometimes we know why. The lead wire can become damaged or can move away from the nerve. We call that lead migration. So for example, sometimes patients come in and say, oh, yep, I was maybe riding my horse or riding my bike. I fell really hard on my bottom, and it just hasn't been the same since. And we do testing and we find out that the lead wire no longer is working. And that does require us to remove the wire and replace a new wire. So that can happen sometimes. It's not a common occurrence, but it can happen. And when it does, though, the only thing really available is to, especially in women who have experienced good results in the past and then no longer are because the wire is not working, then what we do is we just remove the old wire and place a new lead wire. All right, I think that's all the questions. Again, I really appreciate all of you taking time out of your busy schedules. I hope that this was helpful. If you have more questions, like I said, you can call in and leave a message through our nurse and we can call you back. Or we're always happy to see you in the clinic for a visit. So hope you guys have a good night and blessed holiday season.